Welcome back, nursing students and potential critical care nurses out there. Now, as promised, my first video will encompass around sepsis. Sepsis is huge right now. It's so huge. Hospitals are instituting their own sepsis protocols and bundles in order for doctors and nurses like myself to recognize early onset sepsis and to treat it aggressively, right? So my hospital has this fireball, this sepsis alert that pops up on everybody's screen that says, hey, you know what, public service announcement, a patient in your department or a patient that you might have been taking care of is potentially septic. Does anybody know about this patient? Is appropriate things being done to this patient as far as like antibiotics within an hour, lab draws, cultures, lactic acid? So it's a public service announcement. Anybody who accesses that patient's chart has will see pretty much on their computer screen every time they log in, right? So it is huge right now. So this is one of two videos that I will talk about. The first video, I'll pretty much will just give you an overview on what is sepsis, how to recognize early signs and symptoms of sepsis, how to initiate bundles, how to pretty much prevent sepsis and treat it in the initial phase, right? So ask yourself, what is sepsis? Sepsis is an overwhelming bloodstream infection that is causing some organ dysfunction, such as your kidneys, your heart, your brain, your lungs, your liver, your bloodstream, as far as like your coags, is causing some organ dysfunction. And it's caused by multiple different etiologies, such as pneumonia, urinary tract infections, pyelonephritis, cholangitis, meningitis, osteomyelitis, endocarditis, right? Necrotizing fasciitis. There's multiple different etiologies behind sepsis. Most common will either be skin, lungs, or kidneys. Those are the three most common ones. Those are the cardinal ones. All the other ones are potential causes, and you have to kind of understand what can cause those. Like an IV drug user will most likely get either a skin site infection or something like endocarditis, right? Somebody who has a urinary infection, who's taking antibiotics, who says, hey, you know what? Discharge instructions, come back if your symptoms get worse. You start having flank pain, chills, fever, shortness of breath. That's why we give these instructions, because the patient might be on antibiotic, finish the whole course, and start having increased symptoms. You know, think about pyelo, think about sepsis. Or they might just be recently traveling to another country and contact some sort of superbug in another country, and it becomes septic that way, okay? Such as like pneumonia or something like that. Okay, so the mainstay treatment for sepsis is either to prevent it or to early recognize it to prevent it from getting worse. So preventative factors for sepsis is to follow your hand washing techniques. Educate family members to get pneumonia vaccines every 5 years for their elderly patients, or flu vaccines for the young, for the immunocompromised, and for the elderly people, because these are going to be your high-risk people who can contact sepsis, right? And then if your patient is ventilated in the hospital, use your VAP bundles, right? What else can you do? Remove any sort of catheters as early as you can, such as like Foley catheters or PICC lines or ART lines or central venous pressure lines, right? Because any sort of catheter going inside the bloodstream is a potential site for infection, right? So there is a model that we use in order to actually state, hey, is this patient really septic, or is it another physiological response, such as pain or drinking a cup of coffee or just being in the hospital, being anxious, right? It's different. So I use a pyro model to actually tell myself, is this patient truly septic, or is this just a false alert? And we treat it, and if we find something, then we can go ahead and treat it that route too. Okay, so sepsis alert is going off. It activates everybody. Co-septic, room 3, you put the patient on a monitor, their heart rate is pounding above 90, they're short of breath, you know, they're sat in 100%, they have no crackles. They're a 22-year-old female who has no medical history at all. She says, hey, I'm just really scared of hospitals. You just activate a sepsis alert for nothing. So use the mnemonic pyro. We'll go over it right now. The P stands for predepositions. What pre-exposure factors do I have to actually put me at risk for sepsis? Am I immunocompromised, such as like diabetes, long-term corticosteroid use, chemotherapy, malignancy, HIV? Am I elderly? Am I young? Am I a preemie baby, right? Those are predepositions. Am I up on the floor in ICU or PCU intubated? Right? You think about ventilator-acquired pneumonia. Do I have a Foley catheter in? Do I have any sort of prostate issues that, make me have urinary retention? Those are predispositions for infection, so think about it. And did I just get done with the course of antibiotics and my symptoms are getting worse? Now I'm having coastal vertebral pain in my back. That's a predisposition. Did I just come from surgery 3 days ago? My skin site looks red, angry, it's warm, it's whooping, purulent, odorous, pussy discharge from it. Predeposition, right, post-op. Did I just get a pacemaker put in my body and now it looks infected, or a port cath and now it looks infected? Did I just get open heart surgery or valvular replacement? Predeposition, right? So ask yourself, is my patient having any sort of predispositions to become septic? And if yes, then you're moving on to the eye, right? So what is my insult? Am I having short of breath? Am I hypoxic on a monitor? Am I having bilateral crackles in the bases? Right? That's your insult, right? Just like I said, did I just come from surgery? Is my skin angry? That's your other insult. Do I have prostate issues, or do I have a Foley catheter that's been in for the past month and now the cloudiest urine that you've ever seen in your life is sitting in the bag chamber? That is your insult, right? Now you're thinking of severe sepsis. Then we go with SIRS response. So SIRS response stands for Systemic Inflammatory Response Syndrome. Right? You have your cardinal signs, which would be an increased heart rate above 90, increased respiratory rate greater than 20. And what this is saying is that, hey, you know what? These are early compensatory factors my body goes to in order to fight off stress, in order to perfuse those vital organs I need in order to maintain my hemodynamics, right? So my heart is pumping really fast to help pick up more oxygen. I'm breathing really fast to help put more oxygen in my bloodstream in order to feed my hypoperfused organs. And also we go with the end-tidal CO2 or PaCO2 less than 32, pretty much carbonic acid that comes back to the venous system. You blow off carbon dioxide, it measures it, your CO2 reading is less than, say, 32. That is another sign we can use for our SIRS to diagnose this patient might be septic. Is my blood sugar greater than 120 with the absence of diabetes? Right? Am I altered? Do I have any sort of creatinine change? I think it's like 0.5 from my baseline, or do I have a creatinine of 1.3 or greater? That is another SIRS response. Another mainstay one is going to be temperature. Preferably we do a core temperature, a rectal one. Am I above 38 degrees Celsius, or am I below 36 degrees Celsius? Am my white count above 11,000 or less than 4,000? Is my lactic acid level, which is the sign we use to say, hey, you know what? Your body organs are being hyperperfused. The byproduct of that anaerobic energy will be lactate. Is it greater than 2? If all those come into play, this patient is obviously sepsis. So you might get 2 of them, you might get 3 of them. Anything above 2 is going to definitely be a septic workup, right? So then once your patient meets SIRS, we go to organ dysfunction. We get our labs back. We look at kidney dysfunction and elevated creatinine level. We look at elevated LFTs or bilirubins. We might do an ABG. We might see PaO2, FiO2 ratio less than 300, which would mean acute lung injury, or less than 200, which means we're progressing into ARDS, right? And any sort of ALOC in your patient will be an organ dysfunction of your brain, right? Especially in the elderly or your kids will become very, very lethargic and altered if this severe infection affects their brain. Okay, so then we go with what diagnostic tests do we need in order to find this causative agent as soon as we can. Diagnostic tests such as lactic acid, blood cultures ×2, right? We also do ultrasounds, we do CAT scans, we can do echocardiograms to rule out endocarditis, we can do lumbar punctures to rule out meningitis, we can swab the wound, right? Send that down in the culture lab. And then that's it. We have pretty much as long as we have our blood cultures drawn, we can start our antibiotics, okay? But we'll go over the signs and symptoms of somebody in severe sepsis right now. So neurologically, I will be very restless in the early stages of shock, septic shock, but I'll be very altered in the late stages of shock. So anything less than 8, GCS less than 8, we are definitely intubating this patient to protect their breathing and airway. Okay, as far as my heart, I might throw some tachydysrhythmias. especially if you had other comorbidities as far as like heart surgery, coronary artery disease, acute MIs, pacemakers, electrolyte imbalances, and stuff like that. CHF, any sort of cardiomyopathy with sepsis can definitely lead to cardiogenic shock on top of that. So also keep that in mind too. And also keep in mind your patients who are on beta blockers. They might not compensate, right, with the tachycardia. So recognize that, okay? As far as breathing, we do an ABG. We look at your pH, CO2, bicarb, PaO2, and we also will look at your PaO2, FiO2 ratio, right? Liver, we're looking at bilirubin, LFTs, AST, ALT. We're looking at coags as far as like PT, PTINR, and then make sure those are not elevated too, and your liver is able to do the job it needs to do to metabolize these drugs, right? Then we're looking at kidney dysfunction. Is my urinary output greater than 0.5 through 1 ml per kilo per hour times 2 hours? So if my lady weighs 90 kilos and I'm in the 20 cc's per hour times 2 hours, I might try to get an increase in my crystalloid maintenance from the doctor. I'll just phone him in and be like, hey, you know what? It's only been 20 the past 3 hours. She's at 100 cc's per hour, and he might give you an order to bump it up to 200 cc's per hour. Okay, as long as you don't put your patient at risk for R's, they are not a dialysis patient, they don't have CHF, their BNP is not 1,000, then it's okay, right? So then we go with how do we treat it? So I believe the CDC recommends that we actually treat sepsis within 1 hour of the patient being triaged through the doors. So 1 hour we have to give a patient broad spectrum antibiotics. So we cannot give these broad spectrum antibiotics until we actually draw blood cultures. If you have very, very difficult getting these blood cultures, do not let that postpone the treatment, because evidence shows mortality rate increases 8.4% if antibiotics are not given within the 1 hour of the patient hitting the doors. Okay. Then we're considering also giving crystalloids, which is most likely will be normal saline, could be lactated ringers. And we do 30 mLs per kilo. So a patient who is going to be 80 kilos will get 2.4 liters over 3 hours. We used to do it just bolus, but then a lot of patients were going into ARDS, a lot of patients were going into fluid overload. Nurses were just like pressure bagging everything in at one time and making the issue worse. So what we do now is over 3 hours. So you can titrate based off your patient's MAP. So we like to keep a MAP above 65, mean arterial pressure, which is the very basic minimum your organ needs in order to metabolize aerobically, right? Your organs are being perfused optimal if your MAP is above 65. Look for changes in MAP2, so systolic blood pressure. So when a patient comes into the hospital, he's 130 systolic blood pressure, he's getting fluids very slow. You see his blood pressure start trending down, so now it's 90 over 54. Your patient was not in septic shock when he initially got here, but he is now progressing over into septic shock. So I would go ahead and pump that puppy up, run those fluids a lot faster, do a fluid challenge, and see how your patient responds to it. If they got a maximum 30 mLs per kilo and their blood pressure stays below 65 MAP, then we will recommend this patient will get some norepinephrine or vasopressors. At this time, you're considering calling a doctor so you can put an IJ central line in this patient, because you cannot run levofed, do peripherals. I've seen the results of that. The arm starts getting black and tissue starts necrosing. So you need a central line. Okay, you can run it initially, but I would recommend not leaving it there long term. I believe my hospital is 24 hours and you have to take it out and put it in the central line, okay? Other than that, I recommend reevaluating your patient. Once all these fluids are given, reevaluating your blood pressure, reevaluating your lactic acid level, right? Reevaluating your urine output if you do have an increase in maintenance IV fluid solutions. Reevaluating your patient's mentation status to make sure you don't have to intubate this patient. Reevaluating your lung sounds, making sure this patient is not going into ARDS, right? So once you address, assess, and you treat, you have to evaluate. You have to reevaluate this patient. And if the things are not going the right way, you have to maybe take a different angle. If we can catch this early or even prevent it, we have saved a life. It is going to hit us hard this year, guys. So please, please, please follow your PYRO model. Follow your hospital institution sepsis bundle protocol. Get those antibiotics in within an hour. Get those blood cultures drawn as soon as you can. Ask the charge nurse or your coworkers for help, because understand these patients, they come in, they are time consuming. But I'm telling you, we address it fast, we stay ahead of that sepsis curve, you will definitely save a life, you guys. So I really hope this first video has helped you guys. Take care and study hard, baby.